Welcome, Dr. Malhotra.
Hello,
Good evening.
Sir. Good evening.
So good evening.
Good evening. Good evening, everyone.
Would you like to check
Hello.
your presentation once?
Yeah, if you would like me to.
Yeah, a couple of 2-3 minutes left. You can just quickly check and.
Yeah, sure.
Monty sir, we will go directly from your welcome and introduction to Dr. Andrew's talk.
Yeah. I'll hand over to you. Then you will invite. Okay.
Yeah, I will skip my
Okay.
a couple of slides, so that will give us extra time.
Monty, you're happy?
Yeah, it looks good. Just
Yes, sir.
go to next slide. Okay, take it. No problem.
We are live on YouTube, sir.
Yeah. So we have a couple of minutes left.
So, Abhay, were you saying that I'll just start the session after Mohanty's introduction? Is that right?
Yeah, so I'll just kind of welcome you to the talk rather than me spending a couple of minutes introducing the order of the program. We'll save that time and go directly to your talk.
Okay.
Welcome to Dr. Bhosle, one of our senior members.
Yeah, thank you very much. It's
Hi,
pleasure
sir.
to
Good
be
evening,
part.
sir.
Good evening. Good evening. Hi, Rajesh.
Good evening.
Hi.
Welcome, Bharat Bhai, Dr. Bharat Modi, our past president.
Hi, gentlemen. Nice talking to you and seeing you talk, brother.
Good evening, sir. How are you, sir?
Good evening. Thank you. I'm well and hope all of you are safe.
So far, so good, sir.
Looking forward to this teaching experience. I'm in a casual dress. That's why I'm not starting the video.
I would like to see that.
You are depriving us of all the fun, huh?
It's Saturday evening. You could show us, you know.
I know that's exactly. I'm nurturing a glass of wine as well. So,
you described everything, so might as well show now.
It adds to the pleasure of the academics, sir.
That's evidence. That showing you is evidence. Up to now, it's only claims.
Yes.
You know, Gujarat is a tri-state, don't you, Asit?
I'll start sharing. It's 7 o'clock. I'll start sharing my screen. Am I visible and audible?
Yes, Shubhranshu.
Yes, sir. Dr. Swapnil, can we mute from the central console?
Okay. Good evening, dear friends. Greetings from Indian Arthroplasty Association and welcome to the 19th webinar of the IAA 360-degree webinar series. Now, we started in 1995 and completed 25 years last year. Now, that last year being the pandemic year, we started with this webinar series and continuing this year, which will end in our annual conference of Indian Arthroplasty Association in October this year. You can find more about the association in our website, www.indianarthroplastyassociation.com. And if you have got any suggestions, please email us at indianarthroplasty@gmail.com or at my personal email ID, drssmohanty@hotmail.com. I am Shubhranshu Mohanty, the present president of this association. Now we have two WhatsApp groups for our live members, IAA1 and IAA2. All the live members have been enrolled into these WhatsApp groups. But if you have not been a member of this group and has become a live member, please write to me in my cell phone, that is 9869794189, so that I can make you a member for one of the WhatsApp groups. Every day we discuss about the difficult and interesting cases in these groups, about arthroplasty cases, of course, and you will enjoy, joining these groups. Now today, as I told you, it is the 19th webinar in a series, and it is focused on total knee replacement in varus knees. We have been focusing, Varus knee. We have discussed enough throughout many webinars during this pandemic, but this one with a different flavor. And no other than Professor Abhay Alens, the professor and head of orthopedics at All India Institute of Medical Sciences, Jodhpur from Rajasthan, India, is the convener, and he has put in a lot of hard work to make this webinar a success. And we conduct our webinars on the third Saturday evenings of every month. And today is the third Saturday, and it is being live streamed in IAA YouTube channel as well as IAA Facebook channel. And today's webinar have been supported by academic contribution from Corona Remedies Private Limited. Dear friends, we have two internationally renowned guest speakers today for our webinar. Mr. Andrew Porteous is a lead knee surgeon at Avon Orthopedic Surgeon, Bristol in United Kingdom. He's the founding partner for the knee specialist group as well. He's the president of British Association for the Surgery of the Knee. He's a master's in orthopedic engineering as well and awarded Basque President's Medal. He's an editorial board member of the Knee Journal. He's a reviewer of Bone and Joint Journal, European Journal for the Knee Surgery, Sports Traumatology and Arthroscopy. And there are plenty, enormous number of publications of Andrew, and his focus in the knee research. Welcome Andrew to the webinar today, and I thank Andrew on behalf of Indian Arthroplasty Association for contributing today for this academic program. Thank you, Andrew. Our next speaker is Professor Mohammad Abdel Karim, and he's a professor in trauma and orthopedic surgery at the Cairo University Hospitals in Egypt. His interest is primary revision arthroplasty and pelvic trauma. He is closely associated with the AO trauma and is the international program editor of Pelvic and Acetabular Education Task Force. He is in the AO Trauma Egypt Education Committee member as well, and he is AO Recon National, Regional and International faculty as well. We welcome Professor Karim today to our webinar, and we thank Professor Karim on behalf of Indian Arthroplasty Association for joining this webinar. Then we have our own, Indian Arthroplasty Association members from India. Professor Pradeep Kunuz is the professor in orthopedics at Christian Medical College, Vellore, and at present is located in Australia for a short time. Welcome Pradeep for this webinar. We welcome Professor Parag Sancheti, who is the director and professor at Sancheti Institute of Orthopedic and Rehabilitation. He is the past president of Asia Pacific Arthroplasty Society and past president of Maharashtra Orthopedic Association as well. And at present, he is the president-elect for the Asia Pacific Knee Society as well. We welcome Parag to the webinar. Professor Rajesh Malhotra is, well known to this Indian crowd. He's there in every webinars. Professor Rajesh Malhotra is a professor and head of orthopedics at All India Institute of Medical Sciences, New Delhi. And welcome Professor Malhotra today to this webinar. Professor Jay Tilak is a professor in orthopedics at All India Institute of Medical Sciences, Cochin. And welcome Professor Tilak to this webinar as well. Now, couple of rules, disclaimer that in view of the stringent patient privacy laws in our country, any breach of confidentiality of patient information during the course of this clinical meeting would be the complete responsibility of the presenter. The Indian Arthroplasty Association would not be held liable in case such a breach were to occur during the meeting or from viewership of the proceedings of the meeting in the near and distant future. Moreover, for the viewers, a digital online platform is connectivity dependent. We would request the participants to kindly bear with us in case of an inadvertent technical failure hindering the connectivity of our meeting. We express our sincere regrets in the event of such an occurrence during the meeting. I thank you. Now hand over the proceedings to our convener, Professor Abhay Alens, to proceed with the meeting.
Thank you very much, sir. For the lovely introduction. We have a host of very, very well-known and experienced arthroplasty surgeons with us today. And the topic is very conventional, total knee arthroplasty for varus knees. But if you look at the literature, we have some excellent results with over 90% survivorship of knees in more than 15 years and about more than 80% survivorship at 25 years. But despite having all those issues, there are still a subset of about 15 to 20% of patients who are unsatisfied with their total knee arthroplasty, which makes the fraternity look at what it's doing to reinvent itself, to research what is happening to the knee arthroplasty, which brings us to certain very key and important points that we are going to be discussing today. And without waiting faculty to start off on the alignment in total knee arthroplasty, kinematic alignment versus mechanical alignment, and what is his take and his practice in the UK. Andrew, all yours.
Thank you very much. And while I just get this presentation up and going, thank you so much for the invitation to join this great meeting and this great organization. And hopefully I can just share some thoughts as to where I think we are with alignment at the moment. For those of you that will know, the search for the Holy Grail comes out of King Arthur's legends and medieval knights and people that really searched for what they thought was the ultimate goal. And I think with knee replacements and total knees, we're probably looking in this alignment area as to where our next breakthrough or improvement might come. It's a complicated area, and we're doing this in a fairly short space of time. So I would point you to these two articles as a reasonable source of getting to the detail and understanding the definitions of the different terms. But you might say, why search for that Holy Grail? Because, as has already been mentioned, traditional knee replacement, excellent long-term survivorship, but we know that some patients function very well, others perhaps not so well, and dissatisfaction reported in about 20%. And part of the problem I have at the moment is that every new marketing company, every new person you speak to has a philosophy, a technique, an implant that is claiming to miraculously sort out this 20% for you. And the answer may actually be more to do with patient selection or psychology and all the sorts of things that we as orthopedic surgeons don't like getting involved with. But we're certainly trying to find solutions for this in areas that we can influence, such as the knee itself. And there's certainly some evidence that more natural alignment and fewer releases tend to give better satisfaction and function. But we've already got a perfect example of this Holy Grail in terms of alignment, balance, and satisfaction. So if you look at unis in this particular persona partial global trial that I was involved with, and I was involved in the design of the PPK. But the interesting question, I think, for me is if you look at the study and this "does your knee feel normal to you" question, then at 1 year, 92% saying it always feels normal and 8% saying sometimes normal. But satisfaction rates reported in that paper or study, 97% satisfied or very satisfied. So if we actually go to the uni world, where we are preserving the envelope and so on, the ACL and everything else, we can seem to get those things that we're striving for. And so actually, when we're talking about Varus knees, this sort of X-ray in my practice is probably going to get a uni most days of the week. And on our national registry, over 30% of my primary arthroplasties are unis. And certainly with the Varus knees and during the pandemic, where we can get these in as day cases and so on, that proportion has gone up recently as well. But essentially, we are respecting the ligaments, we're respecting the ACL, we're just doing a resurfacing within a soft tissue envelope and not overcorrecting the knee, and we seem to get very good results. So what I'd like to do in the time we've got available is just mention some of the issues, because there are a lot of issues to take into account and we can't cover all of them, but look at the main two concepts, a bit of a comparison and some comments or opinion at the end. So I think some of the things we have to take into account are some of the historical alignment papers did not use long leg alignment films. So some of what they say may not be exactly what we're looking at today. The ACL is essentially resected in all total knee replacements. And so achieving fully normal kinematic behavior is probably not possible if you start by removing the ACL. All of the values we look at in terms of number of degrees of valgus or varus are averages, whereas our patients are individuals, and most of our implants are designed for mechanical alignment. So we need to be a little bit cautious that in striving to be better, we don't actually risk some new or different problems. And one of the big issues is all the definitions. So if you start looking at alignment, people are talking about anatomical, constitutional, kinematic, restricted kinematic, and a whole lot of other terms. And you need to understand what they're talking about if you're going to assess if that alignment plan is for you. There's also the concept of how bad the knee is. So the sort of knee that I say I'd probably do a uni on, or in the USA might be the standard sort of one that gets a total knee. It might be easy in that knee to look at the joint surfaces and extrapolate from the amount of exactly where the surface is going to be, which some of the kinematic techniques do. But as you get to these knees on the right, it becomes more and more difficult to say in that knee, where did that surface used to be and how much wear has there been? So I think complexity of knee also influences your strategy. So we know about all the alignment sort of markers that we're going to use, but the point of this slide was to look at the left of those numbers and all of them plus minus 3 degrees. So actually there's a wide target zone of about 6 degrees for all of these different measurements. And so this is where the issue comes as to if we purely base ourselves on averages versus do we try and do what's right for that individual patient. So these two pictures here, both of them very high performing international rugby stars. One of them is valgus, one of them is severely varus. Both of them function perfectly. And both of them would probably be really unhappy with a knee replacement if you change them into the opposite alignment. We know from Bellemonts's work that at least 30% of normal men have overall varus that's more than 3 degrees. But the converse to that argument is 60 to 70% of people do fall in about that neutral zone that we were looking at with traditional mechanical. I think one of the key bits for me is understanding the influence of your bone cuts. So your bone cuts determine both your overall alignment, but also your joint line obliquity and also your balance. So if, for example, instead of the black line on the femur, we were to do that red line cut, we would align the knee in valgus, we would put more tibial slope onto it, and we would make it tighter medially than laterally. So you have to try and juggle all three of these things going on at once if you're going to play with alignment. So the traditional mechanical alignment is aiming for overall neutral by putting each implant 90 degrees to the mechanical axis of each of the bones involved. We then are taking the average 3 degrees of varus out of the tibia. We're making it into the femur so that we have a parallel gap. And then when we take that knee into flexion, we have to externally rotate it that 3 degrees to get a balanced gap. So that is essentially traditional mechanical alignment. We know from Bellemonts's work that if you have varus knees that are left a little bit varus, 2 degrees or so, they function much better. But that paper, they were actually aiming to put them in straight, and it's just that quite a few of them still landed up being a bit varus. So they went and re-looked at that a year or two later with another publication, saying that actually with modern jigs and the way we do knee replacements, a lot of people still land up slightly undercorrected in their original deformity, even if you're aiming for straight. And that then raised some caution about what happens if you aim for some malalignment, if you like. Don't you become more dangerous for getting even worse malalignment? And this was also borne out by a French study where they showed that actually in experienced surgeons, you often achieve slight undercorrection even when you're aiming for neutral. So that's something just to bear in mind if we're starting to try and push the boundaries of the target. There's another slight variation of mechanical alignment, which allows you to put in 90-degree cuts on femur and tibia, but with an asymmetrical implant. And this one is the journey from Smith & Nephew. It builds in that tibial slope within the joint, but with the standard bone cuts. So that adds another little twist to mechanical alignment. But if we get onto kinematic, then the essence of kinematic is that you're trying to just resurface to where the joint surfaces used to be. So you're slightly compensating for what the wear is in judging that. On a more scientific basis, you're aiming to align them along the knee kinematic axes of the two femoral condyles. It prioritizes the femoral restoration, and if any further minor balancing needs to be done, it suggests that that is done with a minor tweak on the tibial side to adjust the balance. Now, that was mainly Steve Hull suggesting that, and originally doing it with PSI, and now subsequently saying that perhaps one can also do it with more normal instruments if you start measuring your resections and the thickness of your saw, and you can get an approximation of this technique with more normal methods. The issue here is always, if you're trying to restore what the joint was, and it was a pathological joint to start with, is that a good target to be aiming for? There's also a variant of this called inverse kinematic from a Belgian group that have suggested you prioritize the tibial slope and the tibial surface as your landmark, and you make your minor adjustments on the femur if you need to. But if we go on to another quite popular version of kinematic, this is restricted kinematic. And essentially what they're trying to say is that it's the kinematic principle, but you don't want to get really weird results. So it's a kinematic principle, but with a couple of boundaries put on it to give you a safe window. And with their restrictions, it's the components within 5 degrees of mechanical on each side as a maximum, and the overall alignment within 3 degrees. So they're trying to say, we quite like the idea of kinematic for the ligaments and the balance, but we don't want to go outrageous with the alignments and land up with problems. The problem is, to do that finessing and compromising, it probably requires navigation or robotics to enable you to achieve that. So if we think that being more natural and considering the soft tissues and obliquity is a bit better, why are we still considering mechanical? And it's mainly about the load, because we know that as soon as you get past 5 to 10 degrees of Varus, almost all the load goes through your medial side, and the poly stresses and wear much prefer even load distribution, and it's probably better for implant fixation. We know from the original Ritter paper that leaving knees in too much varus, and particularly if that varus is on the tibial side, changes revision rates. Again, a lot of the older papers not on long leg films, but from the alignment they had on shorter legs, that was a reasonable conclusion. With kinematic alignment, this doesn't always mean that you are left in a lot of varus or a lot of valgus. It may just change the obliquity of your joint, depending on the patient. But there is data suggesting changes and increases in the proximal tibial strain with those kinematic alignment patterns on the tibia. There's no long-term survivorship data, but small series with about 10-year follow-up from Hull's group suggests the survivorship is about equal. So if we think that survivorship might be an issue or not, then we have to consider that we really want the function to be better. In mechanically aligned knees, we know by planning them, slightly under-correcting them, they do better functionally than if you strictly go for 0 or if you overcorrect. But what about comparing mechanical and kinematic? So if you then look at functions and PROMs, there are not many studies, but then there are numerous systematic reviews and meta-analyses all looking at that same group of studies. And some of them suggest slightly better function and range of movement in the short term with kinematic. If you then look at one of these reviews that is out to 2-year follow-up, then actually no difference in 4 out of 5 of the RCTs, and in one of them, kinematic was better. And if you look at the RCTs comparing the two, 4 of them say kinematic functions better, and the other 7 at this stage say no real difference. So there might be some benefit, but it's not completely convincing that it's definitely the way forward. So in my opinion, I think it's more important that we understand each individual patient's alignment, their joint line obliquity and their deformity. I believe we have to teach our trainees to do an accurate, very reproducible mechanical alignment first. Then they can start trying to introduce a more sympathetic mechanical alignment, if you like, so keeping them a bit more varus. Katani suggests doing it with a degree or two more varus on the distal cut of the tibia, distal femur, but you can also do it with adding a fraction of varus to your proximal tibia. But ideally, you want your varus knee to be neutral to a little bit undercorrected. Mechanical alignment, I think, remains the standard that we have to compare against, but probably neutral alignment for everyone should now be questioned because everyone isn't normal. Every patient is different, although a lot of them fall within that ballpark of the old neutral mechanical. The early results for KA are promising from a function point of view, but there are some long-term polywale loosening issues that probably still need to be addressed. I think assessing the individual alignment of your patient in front of you is important. Aim for the slight correction, but certainly don't overcorrect your varus knees. And I think if you're considering kinematic, you need to be an enthusiast. You need to really get into it and understand alignment and all the detail of what it is you're actually trying to achieve with that knee. Issues that we still need to resolve include: what are the safe windows for kinematic alignment? How do we get to teach it to all surgeons? Does it require advanced technology or cost? And will it possibly require new or custom implants in future? Thank you for your attention.
Thank you very much, Andrew. It's a very lucid elucidation of what kinematic and mechanical alignment is. So I would now request Professor Karim to start off his talk on soft tissue surgery. And before Professor Karim starts, I have a quick question for you. So is kinematic alignment or mechanical alignment or a restricted alignment, is it something that you practice as a process, or do you do it? Are you going to be telling somebody that you become a mechanical alignment surgeon or a kinematically aligning surgeon, or is it something that you do on a case-to-case basis?
So what I try and do is I'm not doing kinematic in the strict Steve Howell description of it. And we're not routinely using navigational robots for routine knee replacements. So we can't be doing the true restricted kinematic. But what I do is every single patient, I get a long leg alignment film, I measure their alignment, I measure the angle I'm going to put on it, I do the bone cuts, decide what their bony alignment is, then look at their balance, and then decide from their balance, am I going to slightly change the bony cut to correct the alignment and balance, or am I going to look at the ligaments? So if you like, I probably see myself as being a sympathetic or personalized mechanical alignment, but I haven't quite got to the point of feeling that I'm convinced kinematic is so much better that I'm prepared to take some of the risks around the edges, because in my teaching practice, I'm not convinced that I can get my registrars at this stage to do it reliably. So I'd much rather they learn to do a very good mechanical to start with. So that's where I'm sitting with it at the moment.
Vic, can I ask a quick question from Andrew?
Yeah, sure.
Allowed? So Andrew, I'm asking this because you do uni as well. And the perfect knee to do a kinematic alignment is the AMOA, the anterior medial osteoarthritis. And since you are doing uni as well, so do they not compete with each other? How do you decide which one to do uni and which one to do the kinematic?
So I think for me, as soon as they have isolated medial compartment disease, I'm thinking uni, not total. And then I look for a number of other things like the severity of the patellofemoral wear, restriction of range of movement and things like that. But in the vast majority of my varus knees that have correctable deformity, they get a uni. I'm doing my totals more on the rheumatoids, the post-traumatics, the fixed deformities, and therefore I'm going more for traditional mechanical for those ones, but trying not to overcorrect them.
Thank you, Andrew. So may I request Professor Karim to start off with his talk?
Thank you very much for the kind invitation. I'm really delighted to join such distinguished and well-renowned speakers and presenters from India and from UK. I have to congratulate you on the excellent organization. And to be honest, I'm really thrilled to attend that and to tell you a lot of Egyptian trainees are following your excellent webinars. So thank you very much. Today, I'm going to present about achieving the perfect balance on the OR table in cases of varus knee. Let me start by this case of 38 years old male patient who just had this total knee about 2 years before presenting to me. As you could see here on the part of the long leg film, I think this knee was put in without appropriate soft tissue releases for the varus. And that's why no wonder that it failed. And the patient presented just 2 days down the line with disabling pain, asking for something to be done. To start with, and no wonder that Dr. John Ensau thought of the total knee as a soft tissue operation, and failure to address the soft tissue envelope would result in pain, stiffness, and laxity. And that's why I started to open with this case. The objectives of my talk today is basically to discuss some evaluation principles, what is the preferred approach, and then to discuss the sequential stepwise soft tissue releases to achieve soft tissue balance on the OR table. To think of varus knee, we need to understand very carefully the medial knee joint anatomy, including the static stabilizers as well as the dynamic ones. The static would include the superficial as well as the deep MCL, posterior oblique ligament, PCL. The dynamic would include the semimembranosus, the bis and serine muscles, in addition to the medial gastroc. We need to briefly touch upon the physical examination. Obviously, we need to assess the degree of varus deformity, whether mild, moderate, severe, according to different classification. We need to appreciate whether it's fixed or flexible, because if it's passively correctable, we would only need some minimal soft tissue release in addition to the bone cuts and prosthesis. Whereas if it's obviously uncorrectable or fixed, mainly soft tissue balancing and bone cuts would serve the purpose. We need also to appreciate whether the knee is tight in flexion or extension or both. And we need to assess for associated deformities, and commonly encountered one in association with the varus is basically deflection contracture. Right, the first question which could come to mind is whether it's extra-articular or intra-articular, and this should be recognized preoperatively. So preoperative planning or templating is imperative, and to be corrected extra-articularly or intra-articularly, and whether we need to achieve that in a single or stage correction. And these are some cases where the computer navigation or possibly the robotics might have a role. Right, what are the indications of extra-articular correction? It could be done if the femoral deformity is more than 20 degrees, tibial deformity is more than 30 degrees. And also whenever we see that the distal femoral bony cuts would remove the collateral attachments, as we could see here. And the other indication on the tibial side is where the projection of the distal tibial segment axis passes outside the tibial plateau, as we could see here on the figure. Second question, does flexion deformity play a role? All these questions we need to think of whenever we encounter a varus knee. Well, obviously it does have a big role, as correction of the flexion deformity would reduce most of the varus deformity. So it should be treated first or simultaneously whenever we are encountering or correcting for varus deformity. Why that important? Because over-release of the MCL here to correct the varus before addressing the flexion deformity might result in instability in flexion and possibly internal rotation of the femoral component, as we could see here. In addition, overcutting of the distal femur to get full extension might result in elevated joint line height or level. I personally would like to approach the knee, the varus knee, in the standard medial parapatellar approach, It does provide adequate exposure in most knees. It's also extensile and can easily be converted into one of the quad SNP or VY turn down. I would start by sharp dissection into the proximal medial part of the tibia and dissection interval just above the base, but below the joint level, and do supraosseous elevation with one of the cups or pristos. Historically, the soft tissue release included different or numerous methods, no exact consensus so far. Historically, this included the release of the deep as well as the superficial medial collateral ligament in its entirety in some series, in addition to the pes anserinus. Well, this might result in medial flexion laxity in some cases, in addition to internal rotation of the femoral component. That's why I wanted to share with you my preferred approach on the stepwise sequential release sequence. Step one would be what we call the exposure release, where we release the deep MCL in the mid-coronal plane, just about 10 millimeter or 10 to 20 millimeter max below the joint line. In addition to that, I will proceed with the removal of the osteophytes from both the proximal tibia and the distal femur, but also the posterior femur. And then I would resect the extension gap and reassess the balance by inserting the spacer block, assess the balance, assess the alignment. If still this is unbalanced, I will go for additional releases in sequential fashion and reassess the balance if, after each release. So step two, I would go for the POL, posterior oblique ligament, and then reassess the balance. And according to Leo Whiteside, this is the posterior oblique ligament, which lies posterior to the superficial MCL. And they usually say that it's tight, the posterior oblique ligament would be tight in extension, like referring to that like the PE, the famous acronym for pulmonary embolism, while the anterior portion of the superficial MCL is tight in flexion, and that's why they refer to that like AF or atrial fibrillation. Then step three, I would consider the PCL release substitution, making sure that the PCL is resected before balancing. Because in general, what we find that the less soft tissue releases is required to balance the varus knee once the PCL is resected. Going now to the fourth step is the semimembranosus release and then reassess the balance. I think with these four steps, most of the varus knees would be sorted out or balanced well. Then we have also the medial tibial reduction osteotomy and indicated in medial tightness and extension, severe deformities, or whenever we encounter reactive hypertrophy from overloading. And the role is basically this reduction osteotomy, it removes stenting of the MCL, allowing shorter course of the for the MCL, increasing extension gap while preserving the MCL continuity. It does also eliminate or reduces the size of the defect and the uncovered bone. We could do that by just downsizing the tibial base plate and tibial size, just one size below what we usually use. And this results in lateral shifting of the tibial component. And then we remove the extra bone using the power saw or some rongeurs. And then we would reassess the balance. This has been studied in quite a few studies, which showed good survivorship for the prosthesis and good balancing outcome after using this medial reduction osteotomy. Now, going to step 5, which is required in more severe cases, is basically to distract the joint and pie crust the superficial medial collateral ligament using one of two ways, either the knife blade number 11 or one of the angiocath needles or the spinal needles, and do the pie crusting, and then reassess the balance. Coming to step 6, and the last step is usually required rarely and only whenever it's very severe case, by just doing complete release of the superficial medial collateral ligament. In addition, we might need also to release the pes anserinus. And we have to take into consideration that coming all the way down to this kind of release, that the medial side might be destabilized. So we have to have constrained implant is often required to be on standby. Lastly, one of the other osteotomies, or the medial epicondylar sliding osteotomy, might be also used to correct severe varus deformities, and has been studied in quite a few studies and reported good results. But some series, like the one presented here, showed up to 46% non-union. But still, it considered handy in some severe cases. Again, we need to take into consideration that the association with some big posterior osteophytes or flexion deformity has to be sorted out. We need to release these as early as possible. And sometimes even in such severe cases, a preliminary 4 millimeter posterior resection of the posterior femoral condyle, I would start with that before doing my soft tissue releases. In addition, whenever associated with the flexion deformity, we need obviously to release the posterior capsule from the femur and the tibia. We might need to release the gastroc, the medial lateral collateral ligament, and also modify our distal femoral cuts to sort out the flexion deformity. What is the role of bone resection? Well, while majority of balancing is soft tissue in nature, we have to appreciate that tibial resection in the coronal plane varus valgus will affect soft tissues. The femoral rotation clearly would affect also the soft tissue tension, especially in flexion. Just to conclude, coming back to my case, which I just presented in the start of my talk. So basically, by appropriate releases of the soft tissue on the medial aspect of the knee, as we just, and using the sequential soft tissue release in different steps, I was able just to put just ordinary or just LPS in addition to one of the stems. And I didn't need to go even to MCL or complete release of the MCL. So I just want to reiterate that if we follow the principles of following the stepwise sequential release, we would be able to achieve the best results. So in conclusion, we need to evaluate the varus knee, not to consider every single varus knee is a straightforward, easy one. We need to appreciate first whether it's extra or intra-articular deformity. We need to evaluate for associated fixed flexion deformity, which needs to be addressed simultaneously. And we need to follow a sequential stepwise soft tissue releases. The last take-home message and the most important in management of varus knee, the quality of surgery is the single most important factor which determines the outcome. Thank you very much.
Thank you, Professor Karim. That was a very lucid talk. And before I invite the next speaker, which is Pradeep, for his talk on tibial defects, can I ask you something?
Sure.
We'll take the questions in the end, but it's just while Pradeep is loading his talk. Do you have a formula as to how you will classify and quantify the extent of deformity that you release, that you will want to do or need to do in a given case? Or do you take it as a case, individualized case basis with 1, 2, 3, 4 steps in your mind?
Yeah, sure. Well, actually, just because, yeah, sure. Well, I originally including quite a few slides to classify the deformity, but because of the titles of the time, I removed them. So basically, you come across different classification systems like mild, moderate, severe, and sometimes they say 5 degrees, 10 degrees, and more than 10 to 20 or something like that. But also, according to Matthew Abdel, I love his classification, where you draw the mechanical axis from the geometric center of the femoral head down to the ankle. If this line falls in the lateral aspect of the medial tibial plateau, this is considered to be mild. And then if it goes around the margin of the medial side of the medial tibial plateau, it's moderate. And if it fails just outside the knee, obviously, this is severe. Now, I started my training when I was a fellow to say, well, most cases with the mild, I would only need to release the osteophytes and the deep medial collateral ligament. Going to the moderate, I might reach up to the PCL and also semi-mem. And only in the very severe and where I can't achieve that, I might go resort to the others. But to be honest, with increasing my maturity of experience, I start to treat that on case-by-case basis, as you correctly said. So I follow the steps intraoperatively. and then reassess after every single step and see how it goes. But I would expect with the severe cases that I might need to resort to step 4, 5, or 6. But again, it's very, very unlikely to need to go to step 6, to be honest.
Thank you, Abhay. I think there is one more question if we can take from Lupondo. Has raised the hands. Lupondo, you can ask your questions. Can you?
Sure. Sorry.
There's a question from Lupondo. Can you introduce yourself, please?
Hello, I'm Violet Lupondo from Tanzania. My only question was, some of the, surgeons think about not touching any soft tissue. And when you deal with the bone issues, probably you'll have a good balanced varus knee. So what do you say about that? Is it necessary to go to soft tissue? And at what point in time is very necessary to do that?
Well, to be honest, I usually think as presented in the first slide that, like Dr. Insol said, it's soft tissue procedure. So most of the time, unless the medial tissues are not tight or not affected, are quite normal, whereas the deformity comes from the defect in the bones. That's the only exceptional case where I might resort to the bony cut. However, most of the cases, as I just showed, I would treat them on the basis that it's soft tissue procedure, and I will go from step 1, 2, 3, and 4. I don't know whether this is the same case with the rest of our distinguished speakers and also Andrew Porteous. What do you think?
Yeah, Andrew, can you have your comments on this, please?
Yeah, I think it's a good point, and it's certainly, if you read the work of Aaron Malaji, he's very against touching the MCL, but doing other things to try and get the alignment and the gaps right, rather than compromising the MCL. I think the more I've looked at the bone alignment and tried to get that right, the less and less I need to touch the ligaments at all. I think when you add fixed flexion, then you're in a different scenario, and you may need to do releases posteriorly because of the fixed flexion. But purely for varus, I think you make a good point, the person asking the question, that I think you probably need to get to the point of doing the osteophyte release, the reduction osteotomy, look at your cuts, and then decide, am I going to have to fully release this MCL, or could I add 2 or 3 degrees of varus onto one of the cuts to solve the same problem? And that's where I think if the patient has been in severe varus all their life and you're reducing that varus, but you leave their MCL intact, that's probably ideal. But if it's someone who's had fairly neutral alignment, but now they're in bad fixed varus, then those are the ones where I think even after reasonable bone cuts, you may still need to address the ligament. But I think actually doing a superficial MCL release is now a very rare thing in my practice, whereas maybe 10 years ago, it wasn't that uncommon.
Yeah,
Thank you.
Totally agree. Yeah.
Thank you, Andrew. Let's move on with Pradeep's lecture. Then we can have more discussion at the end. Yeah, Pradeep.
All right. So my brief is to talk about the management of bony defects. So I won't be touching at all on the soft tissues. I'm going to be assuming that soft tissues are being looked after. So it's going to be done through a series of cases. But before I start, I'm just to mention that for very minor defects, like the one here, you may just decide to sort of fill up that with a little bit of cement, something like a 2 millimeter defect or something of that sort. If it's a little bit more, some people may use screws, but to remember that these screws, when you're using it with cement, those screws are not for mechanical support. They're actually more like the iron bars in the concrete, more for stabilizing the cement rather than for support. So when you put your screws, make sure that they don't touch the base plate. They should be actually below the base plate, and that's how these screws actually function when you put it along with the cement. Now for the first one, the use of the graft. I'm going to ask various faculty as, just randomly. So Prof. Jaitla, can you just, in your opinion, like when would you use a graft as opposed to, say, cement and screws? Like what are your indications for using a graft?
Yeah, I think if the defect is a bit more than, say, around 5 millimeters or more, and in our part of the world, the patients who just cannot afford a metal wedge, in those scenarios where the bone graft, what we prepare from the femur, if it can be utilized, I would use it. If the defect is around, say, less than 20%, and it's about maybe a depth of around more than 5 millimeters, I would use them. There is a worry that this might get absorbed and will it create problems in future. That worry is always there, but still in scenarios, in situations, we have used it and got away with it. Would always add a stem to the tibia to stabilize the implant better. So that's my thinking.
Okay, right. So Jay brought in two things. One is that if the gap is more than 5 millimeters or so, and you said about less than 20%, especially in a primary knee, when you have ready-made autograft available, you would use that as the graft there, bearing in mind that there may be some problems with absorption. Now, you mentioned this use of the stem. Now, is a stem always necessary for putting a graft in? For example, when I actually just Googled or put it in PubMed, autograft for Varus deformities, and this is the article which I got in June 2021, and this is the picture that they have, the corrected one with mosliced graft and various other grafts, and there's no stem. So my question is, perhaps Dr. Parag Sancheti can take this. When do you decide to use a stem? Do you use a stem for all grafts, or do you have any specific reasons when you would use the stem?
So my indication to use a stem is depending on the size of the bone defect. If it is more than 50% of the lateral or the medial condyle, I would use a stem. Additionally, if the patient is obese, that's one of the criteria also for me to use a stem. And the last criteria would depend on how much deformity was there and what is the level of constraint I need to use. So depending on these 3 points, I would decide to use a stem or not to use a stem.
So there would be situations where you would put a graft and may not use a stem.
No, if I use a graft, a stem is definitely going in.
Okay, so for all cases, so you will not have a situation like this particular X-ray where you have a graft and you're not put in a stem. This probably would not exist.
If there's a graft, for me, a stem is mandatory.
Right. Okay. I think that's a very important point to take. This X-ray may be okay at the end of 1 year, maybe okay at the end of 2 years, but at the end of 5 years, you're definitely almost always going to have a disaster. So if you're going to be putting graft, I think the message is please always put in a stem. Now, whether there's enough and more literature to support the fact that whether you're going to be using an augment or a graft, a stem is an absolute necessity. Whether you're going to use a short stem or whether you're going to use a long metaphyseal diaphyseal stem, I think there's still a lot of debate on that, and I'm not going to be touching that right now. Now, a little bit more of a defect. Now, what if I take the cut here right up to the stable base there, and then just simply put the implant there, stable base, and I use a large insert? What's wrong with this? Perhaps Prof. Malhotra can sort of comment on this. I'm going to use a 15 millimeter insert, or maybe 16, whatever, 17 millimeter insert, and just replace that bone with plastic. I'll maintain the joint line. Is there any problem with this?
Thanks, Pradeep. There are multiple problems with this. One is that the quality of the bone deteriorates rapidly, as we know, as you keep on going down. And that is one problem. The second problem is that you will go on reducing the size of the tibial component. And in certain systems, there may be an issue with the matching between the femoral size, which is not negotiable as per me, because the anterior-posterior dimension of the femoral component will decide the kinematics of the knee. And there may be an issue where you end up having a mismatch where the two sizes are not compatible. So this is something which we always say, this is not the thing to do. I think this is one thing which should not be done is this, because you will really compromise the quality of the bone.
Thanks a lot, Prof. Malsad. This particular X-ray is not of this particular case. So for this particular case, we have done something different. Now, the next question I have, perhaps Mr. Andrew can give his opinion on this. How do you decide whether you're going to be using a graft or whether you're going to be using an augment? Do you have any criteria when you would use one or the other?
Yeah, so I think for me, it's a lot about the patient age and activity level and expected survivorship. So if it is a young patient and I'm thinking I'm going to be going back again in 10 or 15 years' time, I'd try to put some bone back if possible. And they're also likely to be younger, have more decent bone, it might heal in and so on. If you're dealing with an old, frail osteoporotic patient, I think the bone quality is rubbish. There's no real value to adding extra bone, and I'd probably go to metal a lot sooner in an older, frail patient. So for me, that's probably the cutoff: the osteoporosis, the age, low activity level, just put in metal. For the young ones, I might try bone on occasions, although to be honest, most of the time I'll use metal, but it's the younger, more active ones where I will try and put back some bone, mainly for the future.
Does any of the other faculty have any other comments to make about the choices?
The cost is another factor.
Okay,
so
yep.
Bone is just there, and so that's one factor.
Is there any situation where you would use an augment and not a graft other than age? Any situation where you would use an augment and not a graft?
Can't think of.
I mean, some of the indications which is there in literature is like if the quality of the bone is extremely poor, like when you have stress fractures or SLE, sometimes rheumatoid, sometimes or the recipient bone is avascular, an augment may be preferable. Or if the defect is huge, like more than 50% of the condyle, again, there are surgeons who would probably use an augment instead of a graft. Now, for this particular knee, what has actually been done is a metal augment. Prof. Kareem, do you want to critique this particular X-ray or this particular implantation?
Well, I think it's well done. Thank you very much. I could see here we might be a little bit of oversize on the medial aspect, which might cause a bit of some irritation. But I don't know whether you would go for I don't see the end of the stem. So I don't know how long this stem. Probably I might have gone with a little bit shorter one if it's not very long. Yeah, that's my comment.
Okay, yeah, I think the important point is that you brought it out. And that is that the medial side here, especially when you're going to be using larger augments, you do have a problem. Even if you're going to use the same size as what you've taken off, you can have this kind of an overhanging, especially because the tibia is not straight down, it's shaped like that. So when you are using these kind of augments, especially when you're going to be using bigger augments, try and downsize the tibia as much as possible so you can try and avoid having this overhang. Alternatively, there are implants or there are companies which give you the stepwise type of augment, and that's something that you can use. Now, Prof. Jaitilak, what are your comments about using this wedge type of graft of augments? Any comments? As opposed to the block type.
Yeah, I try to avoid those because the shearing force is too much for these kind of wedges. So if I have to use a metal block, a metal augment, I would rather use a metal block rather than a wedge.
Right, thanks. I think that's a very important point. There's a lot of literature and biomechanical studies on that about the usage of these kind of wedge-shaped augments. What happens is when you sort of eccentrically load it like in a Varus knee, the pressures are, that it's the wedges sort of goes outwards, and then you'll have a lot of stress on the stem or on the center stress forces. And in fact, they show this particular picture where the stem has actually fractured because of the stresses. So by and large, try and avoid using this wedge-shaped augments. The same applies for grafts, actually. What they say is that try and avoid these kind of wedge-shaped grafts, those oblique grafts. What is much better biomechanically is use a step cut or rectangular type of grafts. Those step type of grafts that we commonly use is probably biomechanically not as good. Okay, now going on to the next case. This is the X-ray that you have, and this is a patient. So what you have is quite a lot of lateral laxity. So perhaps and that's the medial lateral, but you can see that, the MCL seems to be more or less okay. It seems to sort of come straight. So it's a correctable varus, and most of the problem seems to be from the defect, but there definitely is also a lot of lateral laxity. Does anybody want to take this and say what you would like to use, Dr. Professor Sancheti?
Intervene, Pradeep. Can we walk through what you did, and can we walk through what you did and come back to some questions? Because I guess just
all right,
overrunning our time.
So basically, there was a little bit of problems with the laxity there, both medially and laterally, and so I had actually opted to use a hinge knee for this, and this is a link type of hinge knee. But what I actually wanted to bring out with this was the fact that the gap has really not been, the defect really has not been addressed. And so does Dr. Malhotra want to sort of address that or comment about the defect and not correcting the defect for these kind of knees?
So I would be wary of leaving the defect unaddressed, because that is actually going to increase the stresses. So whatever, particularly when in the face of a highly constrained knee, I think the bony contact and the bony support is of paramount importance.
I think that's a very important point. So there's a lot of these hinge knees which do not allow you to put in augments. And so therefore you have problems with correcting that defect, or rather taking care of the defect. So you have to choose an implant that will probably be able to give you that kind of support, as well as using the hinge knee. So it's very important to correct or to support that implant when you're sort of when you have a defect. So even if you have a huge defect like this, if you have your sleeve, for example, you're going to be giving that support there, which can take care of the stresses in that knee. And so, I mean, this is the last case that I have here in the series. It's slightly different from the other one. And this is the picture where, again, you have the huge amount of medial. It sort of goes on medially, but it's sort of medially, the MCL seems to be intact. So I'll just leave this open for the faculty. This is the last one. Does anybody want to take this case? Prof. Karim, what would you do for this one? What would be a choice?
Yeah, I would tend to use more or less like what you've done, probably what you've done with the last case, similar scenario, like using one of the sleeves in addition to probably according to the, with a non-length or length, this could be decided intraoperatively. But on the femoral side as well, I might use one of those. But preparing that, I might, if I can't save the distal part of the femur, I might resort to one of the more tumor type prostheses. But I think I might go away with using one of the sleeves.
And just a quick comment, Pradeep, if you have varus with hyperextension, then hinge is your implant of choice, always.
Yeah, sure. This is actually a flexion deformity of about 20, so it's not hyperextension. But because of the flexion deformity, you will obviously have to take off more of the distal femur as well. So when you take the cuts here, you want to have, definitely you want to take care of the defect that you have on the medial side. And because you're going to be having problems with varus valgus, you have to use something like a sleeve to take care of the defect. You cannot just simply leave it without correcting that defect. And because of the flexion deformity, you will have to take off more of the femur, and inevitably you will end up compromising the MCL. So we first started with trying to do VVC type of implant, but when we're using the sleeves, the MCL was not competent, and so we had to use the hinge. But the key thing that I'm trying to put across here is that don't forget that we have to take care of that defect. You cannot just simply put a hinge and expect the knee to be stable on a long-term basis. The stresses on that implant would be extreme. We have to also be careful that, don't rely only on the ligaments. An X-ray like this may be okay. Don't think that, the lateral ligaments, the lateral laxity that you saw when you have extreme defects on the medial side, this can cause you problems. 2-3 years down the line, you can have this kind of a situation if your lateral side is extremely gone and you've only put in a VVC. So sometimes this balance between a VVC versus hinged type of implant, you have to take very carefully. So in summary, as far as the tibial defects are concerned, for small defects up to 5 millimeters, you probably could use either cement or cement and screws. For larger ones, you can either use graft if it's a primary one. Larger ones, larger defects, you may use metal augments. If it's a much larger defect, you probably will need sleeves. If you're going to be using a hinged knee, you definitely need to support that medial defect, preferably with a sleeve. By and large, now actually, for most patients, I've started using more of the sleeves and less of the metal augments. It's just easier and quicker. But most important probably is that whatever defect that you're sort of correcting, if it's anything graft or more, you do need a stem. But I think I'll stop here because time is already up.
Thank you, Pradeep. Some great points, some great learning lessons. And without wasting time, I'm going forward to the next speaker, which is Dr. Parag, for his talk on stress fractures in tibia. Parag has 2 lovely cases, which he will share with the audience.
While Parag is sharing the screen, my question to Pradeep is that people would like to know that whenever you are using screw and cement only, do you need a stem extender?
I can't give you the biomechanical this thing on that, but I think for 2 to 5 millimeters, I have not been using stems, especially because I would use it only if it's a very small defect. So I've not been using it. I'd leave it to the rest of the faculty to say what they would use.
I'll just quickly share, when I put the trial tibial implant, I try to rotate it on the bone. If it is stable, rotationally stable, then I don't put a stem. But if I find it rotationally unstable, that means the bone quality may be a little poor. There I put a stem in addition to the screw and the cement.
That is a great point, Mohanty. The other thing is that it is said that if your broach is going through the defect, then you should put in a stem, whatever.
Prem sheet pe bolna, prem sheet pe. Prem sheet.
Thank you.
So just a logistic announcement, please all delegates keep your sound on mute, your speaker on mute. And a request to Violet, she raised her hand. Can you please put your question into the chat box and we will take it after the talks. So please, Dr. Parag.
Thank you very much, Abhay. On the outset, thanks, Mohanty, for the opportunity to be here. And thanks, Abhay. You've been putting a lot of hard work into this webinar. And that's why you see so many nice speakers and so many audience. I'll just share my screen. So the topic which Abhay wanted me to speak on was TKA for tibial stress fractures. What are the caveats and pearls? So, I just put together 3 cases. And before I start, so these are the stress fractures which are not the ones which we see in otherwise normal bone, because of repeated sub-minimal stresses leading to the fractures. But these are the fractures which are seen in arthritic knees because of malalignment, because of the deformities. We see excessive repetitive submaximal loads on the deformed bone causing intra-articular as well as extra-articular so-called stress fractures. So this was one of the cases which I would like to share with you. It's a 58-year-old lady with knee pain since 2 years, and since last 1 month before I saw her, she suddenly started getting more pain. She was finding it difficult in walking, was finding it difficult to put weight. And when she came to me, I had been following her up even before she had this stress fracture. I think it's important to understand how to classify the stress fractures, and Arun Mulaji has given a nice classification on it. It can be intra-articular and extra-articular. Depending on what it is, can be malunited, ununited, or there may be 5 types of extra-articular. The important thing in extra-articular is for me to see whether this is united, if united, malunited or not. And if it's ununited, then to find out what is the extent of the abnormal mobility. So a scanogram for me is a must to find out if there are fractures anywhere else. And this particular case was an extra-articular stress fracture. There's no intra-articular fractures as per Mullaji's classification. It's very pertinent to do a metabolic workup. You know, for us, we will just go ahead and do a knee replacement with a long stem, and that's the end of it. But I think it's important to identify why that pathological fracture or the stress fracture has become, and it's usually a metabolic issue more often than not, osteoporosis, and you've got to find out what it is. After that, so this patient did have osteoporosis. What we did was a standard TKR with a long stem. I always like a PS implant. I'm anyway majority of the times a PS implant user, so it helps, and this is what the alignment was. Post-operatively, we started the patient on calcium, which is very critical, and at that time I was a big fan of using this yearly infusions of zoledronic acid, which I have now changed to, but this is what we used for the patient, and then I referred it to my endocrinologist who took over the osteoporosis management. So coming to the second case, this was a severe varus deformity with an extra-articular fracture. You can see on the right side, she didn't have a fracture, but she could have got it, but on the left, there was this complete fracture. So whenever these fractures happen, they always start with some crack or with initiation. And it's difficult to really pick it up in the initial stage unless you really have a high level of suspicion where you do a bone scan or an MRI. Otherwise, you will not pick it up. I think that's very critical because this progresses quite rapidly than you think. And by the time you see it on the X-ray, it's already come to the stage 3 or stage 4. And I'll talk about the classification a little later. But then it's too late to really prevent it or to think of any non-operative treatment. And operative treatment is mandatory. A bone scan, as I was saying, is quite useful in diagnosing these fractures early. So if you have a patient who complains of a sudden increasing in pain, who has an arthritic knee, who's been following up or finding it difficult in weight bearing, X-ray is normal. Don't hesitate to get a bone scan or an MRI, which will pick up this fracture. For this patient, of course, it was quite obvious that there was a complete pathological fracture. So what we did was, there was an intra-articular as well as extra-articular. Intra-articular was treated with a bone graft, and the extra-articular stress fracture was treated with a long stem, and this was rotationally stable. And this is what we got the fracture united at 1 year, and the patient went on to have a good result. What is important is, the post-operative rehab. For me, I immobilize these knees for a couple of weeks. I don't hesitate. I start the range of motion as per the pain tolerance. I keep them non-weight bearing because you've grafted them, I sometimes now have started doing partial weight bearing, but definitely not full weight bearing. And depending on the radiological union, I would allow them full weight bearing by 6 to 8 weeks. So I'm a little conservative in my post-op rehab. Again, the critical thing, friends, is to supplement these patients in the post-op period. I have now started using teriparatides, and I want to try out denosumab, and we'll discuss it when we have the discussion on what is the best way to treat the osteoporosis aspect in these stress fractures. Of course, the endocrinologists are important, but then I think the orthopedic surgeons should be able to treat this by themselves. The last case which I want to show is from my friend Soundarajan is here, put this up in the CCOT as well. And you can see that there is sometimes, you get a segmental stress fracture. So you have one, and if you don't treat it in time, you can get an additional one. So this was treated with a long stem, as you can see. And for me, an important decision whether to plate this or not is done intraoperatively with a C-arm. What I see is once I put the stem, if it is rotationally stable or not. And if it is rotationally stable, then I will not hesitate. I will not put a plate. But if it is rotationally unstable, if there is some movement, then I would like to definitely use a plate. And this particular plate helps, it just removes the rotational stresses, and then these fractures unite pretty well. So it's not that just you leave them with a stem. As long as you've corrected the alignment, they're going to unite. Sometimes they don't. So I think we have to have have a decision judiciously on the table with the help of II, whether you want to plate them or not. Friends, one of the important messages I would like to give is that we have to have a high level of suspicion. Pathological fractures, these stress fractures, if picked up early, can be prevented from progressing further, can be prevented from becoming complete fractures or getting into malunion or non-unions, and then we can definitely treat them in a different way. So this was an interesting classification which I showed, something similar to an AVN, when the stage 1 and stage 2 can never be picked up on an plain X-ray, and by the time you see them on a plain X-ray, they are quite advanced. So similarly, in this classification, if you want to pick the grade 1s and grade 2, you need to have a bone scan or an MRI, and then these can be managed differently. But once you see it on X-ray, more often than not, they are going to require some surgical intervention. So this is important to know. Another critical thing which is in my mind, which I want to bring out my thought process, is there are 3 ways to treat these patients with stress fractures. It can be non-operative, where you immobilize them, offload them, and they would heal. And then you can come at a later date and think about what to do with the arthritis, or if there is malalignment, what to do with it. If the malalignment does persist, or if you have non-union, then you can plan a 2-stage surgery. You can first plan to get the fracture healed, either by a plate, and if it is united, then you can just do an osteotomy and put a plate or a nail. And at the same time, you have to correct the alignment. You've got to get your mechanical axis passing to the center of the knee. So that's a 2-stage surgery. But for me, non-operative, of course, you can see if they pick them up early. But for me, 1 stage is the way to go, because we can correct all the 3 things: the arthritis process, the non-union, as well as the malalignment, by 1 surgery, which is a knee replacement with a long stem. So that's my rationale, and I've moved to, most of the times, treating these kind of stress fractures with a 1-stage procedure. Implant, what do you use? Of course, you can use a CR knee also if you want, but for me, these are always posterior stabilized components. Usually long stems are enough. You may have to just keep a constraint process ready, especially if you have a very severe deformity where your MCL is incompetent, then you may have to use an increased level of constraint. As I said, an additional plate may be essential, and that for me is an intraoperative decision where I check on the fluoroscopy. If there is rotational instability, I do not hesitate to go ahead and plate it. And this is very important, because if your fracture is rotationally unstable, then you are going to have a problem. It will not unite. One tip I want to give here is, when you ream, be very careful, because if there is a non-union, your distal fragment is going to rotate. So what I do is, I kind of use a strong towel clip or a bone holding forceps, carefully over the tibia, and hold the distal fragment. And whenever you're reaming, go serially with 1 millimeter. Don't be in a hurry. And the moment you hear some crackling noise, please stop. I've burned my fingers, and sometimes, you just want to get a thicker kind of a stem inside. So you ream up to 11 or 12. But let me tell you, that's not a good idea, because the moment you feel there is some crackling going on, then you should stop and just use that size stem or 1 size smaller. Whether to cement the stem or not, we can talk about it, but now I've moved to completely uncemented stems, and that is the way for me to go. I would just like to stress that, 2 things you have to correct when you're dealing with stress fracture is the malalignment. You cannot leave your long axis of the lower limb malaligned, and you've got a knee inside. And of course, correct the concomitant metabolic issue. That is very critical. So in conclusion, I would like to say that have a high index of suspicion when you're dealing with these fractures. They are not very easy problems. You have to deal with non-union, malunion, malalignment, bad arthritis, associated metabolic issues. So please make sure you solve all the problems. For me, currently, 1-stage surgical treatment is the way to go. But if you are in a doubt, if you are having, you're just starting your practice and you don't have much experience, don't hesitate to do a 2-stage procedure. Get the fracture united. get the alignment corrected, and come another time and do a second stage knee replacement. No problem. Preoperative evaluation of osteoporosis and metabolic disorder is very important because you've got to find out the cause. Otherwise, it's going to happen again. Thank you so much for your attention.
Thank you, Parag.
Very much.
There's a question in the chat box by Dr. Ankur Singhal. Would you do anytime, fibula osteotomy when you're dealing with stress fractures?
Yeah, excellent question. So, depending if the fracture is united and then I'm going to correct it with an osteotomy, then that is the time where I will definitely like to do fibular osteotomy.
Okay. I would just like to add two important points that when to do
Yes.
MRI. MRI, I palpate the upper part of the tibia in severe varus knees, and whenever there is a localized tenderness, then I advise an MRI if there is nothing as visible in the X-ray, of course. Because some patients also complain. Yeah, some patient complain of wherever you press on the tibia, they will complain of pain, but that is due to the generalized osteoporosis. But in a localized tenderness is there, I feel in the upper part of tibia, then I would advise an MRI. That's what my protocol is.
Absolutely. Once they give you a point tenderness which is away from the periarticular area, that is the point where you have to have suspicion and subject these patients to bone scan. I've learned it the hard way, and I don't hesitate. Sometimes my non-arthroplasty colleagues in the hospital say, "Oh, why are you doing this?" But then I think one has to have that level of suspicion and go ahead, because you can save a lot of other potential surgeries and avoid your patient subjecting to them. Yes, Ashik.
And another important point is that I put the reamers to decide about the size of the stem extender, the diameter. I put the reamer, and just when it is snugly fitting, I lift the reamer. When it lifts the entire leg with that reamer, then that is the size which I prefer.
That's a good point.
That was proper, proper size. These are just two important personal points. Yeah.
Again, to retaliate, be very careful.
Thank you, Parag. Yeah, thank you very much for some great points and some great inputs. And I now request Professor Rajesh Malhotra sir to for his talk on varus knee mechanisms of failure.
Thank you, Shubhranshu. Thank you, Abhay. We have had some great talks, and it's time to get round to the real world situation where everything is not black and white. There's a whole lot of gray. We'll start by showing you this patient who has valgus on right knee and varus on left knee. And it is now known that the valgus deformities are twice as likely to fail. So that's one way where we part ways, and now we'll talk about the varus deformity. So this is a severe varus. All of us have seen, all of you have seen that. We see that routinely. Pradeep has shown some great cases about that. And we have been attempts to classify them as intra-articular, metaphyseal, or diaphyseal, or the primary varus, the double varus, or the triple varus. Regardless of whatever you use, even attempt has been made to classify the type of the tibial plateau shape, and something which I'll mention soon about the joint line obliquity. But this was mentioned by Andrew. So make sure that it's a long leg radiographs, because 1 out of 3 cases, it may be there may be discordance or misleading thing. Now, again, talking about Andrew, he mentioned this seminal paper by Ritter, where he said that the best survival is between 2.4 degree valgus to 7.2 degree valgus. Moreover, it was said that the varus hip knee axis alignment fails due to medial bone collapse, whereas the valgus fails because of the ligament instability. Now, this paper by Arun Mulaji showed that if you have a preoperative varus of more than 20 degrees and femoral bowing of more than 5 degrees, you have an increased risk of malalignment. So we are talking about all the preoperative factors which can lead to a failure, and we'll continue on that. So now this particular paper said it doesn't matter how severe your varus deformity was, as long as you could align them in neutral. Another paper said the same thing, but said that severe varus, which was left in varus, did worse than the ones where the neutral alignment could be achieved. So the survival rates were better. So all these papers have been saying that you may get away by undercorrection of varus, but long-term survival would be better if you achieve the neutral alignment. I'll keep on ruffling the feathers, but then I think we'll be able to reach some good conclusion. This is another very important factor when we talk about the mechanisms of failure. 27 out of 35 patients in this study who failed had a BMI of more than 40, and it was showed that they had at least 10% more load on the proximal tibia, more than the 300,000 pascals, which was allowed in these cases. Another very important factor, when you have a coronal shaft bowing of the femur, it has been shown that the trans epicondylar axis also goes into varus, and it is really a challenge to get a good coronal alignment in the face of a coronal bowing. So till now, we have decided that the three factors, preoperative factors, which can decide the failure is the severity of the varus, which could make a difference, the bowing of the coronal bowing of the femoral shaft, and the BMI. Now, this is a 56-year-old female who underwent bilateral TKR elsewhere in 2008. This was the early post-operative period, and then she came to us with this kind of failure. And I think I'll not waste the time of the panel by asking what went wrong here. I think we are at least sure of the two factors out of the three which I mentioned there. I don't have the long leg x-rays to see whether the coronal bowing of the femur was present there. Now, this particular paper by Michael Barron showed that the most common mechanism of the failure in varus was medial bone collapse. And then that happened when there was a varus hip knee axis, high BMI, and the tibial component varus for more than 3 degrees. These things will keep on coming because the literature has repeatedly shown that these are the factors to be wary of. And then what was shown was that a varus tibial alignment leads to a tibial base plate migration, even if the hip knee ankle axis was fine. So anytime you have 2 to 6 degrees of varus tibial component alignment, you are at risk of having the tibial base plate migration. There's a whole lot of papers which have shown that the polyethylene damage and all those things can occur with the increased stresses and osteolysis when the varus of more than 3 degrees and joint length elevation of more than 5 millimeter are left. In this particular paper, where there was a malposition of the femoral component, it was said that if you leave the femoral component in more than 4 degrees of varus, then the knee fails, and lo and behold, the failure still occurs because of tibial component loosening. So in a varus, it will always be the tibia which will bear the brunt of the insult and will fail. Now, there are different kind of changes in kinematics and kinetics when these components are put in varus. There are studies to show that when the femoral component is in varus, the contact point of femoral condyle on the tibia moves back on the medial side. And if the tibial component is in varus, then it leads to medial-lateral instability. So this is another paper where it said that, if you are in neutral or in varus aligned, there is no difference in the laxity between the two. And this was immediately followed, not immediately, it's now followed by a paper in 2020 which says it's not always true. Because if there is a varus deformity of the proximal tibia and you have given rise to a varus alignment, it may be progressive. So that's what I was saying. I wish the life was so simple that we could say, okay, you can have varus, there's no problem. But then one study says it doesn't create any problem over long term, the other one says it does. So that's why it's important to get to some sort of consensus. Now, it has been shown that there's a shorter survival rate in varus aligned knees after total knee arthroplasty. And then another study which says mild varus alignment and neutral mechanical alignment have similar outcomes. And then it says that, the slight varus actually might improve the result. So there is actually conflicting evidence. But what everybody agrees about is that don't leave a severe varus of more than 6 degrees. So till now, we have talked about severe varus with deformities. We have talked about the varus hip knee axis alignment, and we have talked about the varus components. Now, what are the strategies to mitigate the varus in order to avoid this kind of failure? So this is a paper which said in a severe varus, if you put in a stem, you reduce the chances of failure. So principle number one. Number two, in morbidly obese, use the stem. It sounds quite intuitive, but you'll be very surprised as to how many people don't put stem in the morbidly obese patients also. But that's another key to avoid failure. The reduction osteotomy was mentioned by Dr. Abdel. For every 2 millimeter of reduction osteotomy, you get 1 degree of correction of the varus. And then there are factors. Now, we sometimes forget that there could be a tibial torsion also. And that's where this paper says that you align your jig to the proximal tibia, because in the presence of a tibial torsion, aligning with the ankle may lead to problem and malalignment. And this paper from Ganga Hospital showed that in the face of a tibial bowing, again, it is very important that you should lateralize the placement of the extramedullary jig in order to avoid malalignment. This particular paper talks about the femoral component, and it said that if you undercorrect and you leave the femur in a bit of a varus, especially in patients with severe varus knees, more than 10 degrees, and femoral bowing more than 5 degrees, and make sure that you use navigation that you don't go wrong, cut the tibia perpendicular to the mechanical axis, but don't exceed 2.8 millimeters of varus on the femoral component, then there was no difference in outcome in this. This may be particularly useful in ladies with big thighs, where, or like the one which Andrew showed, where somebody who had a native varus alignment and you put him in valgus, and or a lady with big thighs whom you have put in neutral, and she'll forever curse you because her thighs will rub together. So coming back to our patient where we started with, there was a severe varus. So the stem was added. The hip, knee, ankle was achieved with a neutral alignment. And you can see that this was actually immediate post-operative, and she's got a good alignment. So what happens over the long-term period? And before that, I'll show you the other patient where we showed that the one who had come with the failure, and this was fixed with the revision here, and using the stem, of course, on both the sides. So what happens in the long term? Seminal paper by Parrott et al., Daniel Berry's group, 15 years. Another paper showing that 15-year follow-up in the primary TKR, another paper with 20-year follow-ups. Everybody says there's no difference between the neutral alignment and outlier. So where are we headed? There's so much of literature talking about varus laxity increasing, and the other one saying that it doesn't matter. Probably the fact that only coronal alignment was considered may be an issue here. And again, Andrew did mention about the constitutional varus, this award-winning paper by Johan Bellemans. And then we started saying that kinematic alignment is possible alternative. And everybody was worried because there's so much of literature saying that the tibia placement in varus leads to failure. So what happens in a kinematic alignment? So it says it can restore function without failure, regardless of the alignment category. Yes, but this is from Howell, and one can understand this is almost like a designer surgeon series. So no difference in survival between the varus and the neutral line. But then what is most important to me, and it has been said, is how is your joint line obliquity? Because whatever your overall alignment, if your joint line is horizontal and parallel to the ground on weight bearing, you are good. So those people with varus who have a horizontal joint line obliquity develop osteoarthritis much later compared to those who have a varus inclination of the joint line obliquity. So probably it's the time we started looking at that. There was a question about the gait analysis, and I think even equally important is to see how the joint line is pre-operatively and post-operatively in weight bearing. Now, kinematic alignment restores normal kinematics, but it does increase the contact forces. That has been established. And then do they not fail? Of course they fail. And they fail if you put the tibia in varus in more than 2.2 degrees. So you have very little margin of error here. You can't just put too much of varus. This cadaveric study where the components were put in 0, 3, and 6 degree varus for kinematic alignment showed if the tibia was cut in more than 3 degree varus, it was doomed to fail. And another mechanism of failure in a kinematic alignment has been shown to be the posterior subsidence And the reason mainly was if you give too much of posterior tibial slope, which is more than 5 degrees, and also the patients if they have a high BMI. So RCTs are still required to decide the clinical outcome of the kinematic alignment versus mechanical alignment. And what we know for sure is optimizing limb alignment will affect periarticular soft tissue tension, knee biomechanics, and implant survivorship. Sagittal and axial rotations are also important, which unfortunately has not been looked at in many papers. The bowing of the tibia and the tibial torsion has not been studied very well. And that's why what is clear to us actually may not be clear anymore, and the concepts may change. So I would summarize by saying that what decides failure in a varus knee is a tibial varus of more than 3 degree malalignment, high BMI, femoral and tibial bowing. But remember, femur tolerates varus more than the tibia, and the post-operative hip knee axis should not be in severe varus. I thank you for your attention and would like to invite all of you to our upcoming annual academic feast on 30th and 31st October, Current Concepts in Arthroplasty 2021. Thank you very much once again to all of you.
Thank you. Thank you, Professor Malhotra. I have a question that what is your cutoff level of BMI to put a stem in?
Anything above 35.
Up to 35, okay. There is a question in the chat box by Dr. Ankur Singhal. Sir, what is the cut of BMI per obese patient for using stem? In that we have already answered. Which stem, short or long stem? What is your take on that?
So we usually use short stem, which would mean that, you know, if the combined length is anything more than 65, we are happy. But I'll use a long stem if I had a patient like Parag.
Okay. So short stem is always cement. So short stem you always cement. It is a 30 mm or
the 30 mm cement I always cement. But if it is 65, then it's a hybrid.
Yeah, Asit, you have a question.
Yeah, for Dr. Malhotra. You know, very clearly you showed in the literature that, you know, aiming for, I mean, more than 3 degree varus in tibia is, you know, no, because it's going to ask for the complication. So currently, are you mechanically aligning your knees, or are you trying to do even, you know, with the concept of kinematic alignment? And if yes, then how you are doing it manually or with navigation?
So that is, we are normally doing kinematic, but we are just doing a postgraduate thesis where all the cases have been recruited, where we have done kinematic alignment on one side and the mechanical alignment on the other side. And what we have done is not to take things to the extreme. We do not lateralize the, so we lateralize the alignment jig at the anchor, but we don't take it beyond the limit. So it's 12.5 millimeter is the maximum excursion which it gives. So whatever it allows varus, we do that. We also do another thing, that when we are putting the femoral jig, we draw a line on the anterior tibia parallel to the femoral cutting block, 4-in-1 block. And we try to make a cut parallel to that. And when we make the cut, we make sure that we measure near the intercondylar eminence the thickness of the two plateaus. And if that is equal, we are happy. We don't, but I will always remain wary of the biggest reservation I've had about 3 degree varus is that there's always a 3 degree, margin of making an error. So it means that if you are aiming for 3 degrees, you could go to 0 or you could go to 6. Now 6 is going to be catastrophic. That's what I feel. So that is why either you use PSI or you use navigation. To me, unless either you are a very slick surgeon or a complete devout kinematic surgeon, for a newcomer, it can be dangerous.
Thank you.
Thank you, Dr. Malhotra. We'll have more of discussion again at the end of these sessions. Let us move on to Professor Jai Tilak from Amrita Institute of Medical Sciences, Kochi. Jai, it's all yours. TKR in varus knee for robotic approach.
Good evening. Thank you. Is my slides, can it be seen?
Yeah.
Okay. Yeah, thank you, Dr. Mohanty. And unfortunately, the All India Institute is still not there in Cochin. I'm from Amrita Institute. My disclosures, our institute did receive institutional support for macro-robotic cadaveric training. This particular robot, what we had since 2017 is a CT scan based semi-active robot, which does give some precise soft tissue and bone cutting. And some of the advantages kind of perceived by this robot is the audiovisual and haptic feedback which you get when you use this robot. So here in this talk, I'll be just briefly explaining a little bit about this, about how we plan our cases, and then ask the panel about what are the real advantages, is it really important or not. So that way we can go through this talk. We have heard about a lot about alignments, and the younger surgeon, when they hear about these alignments, which is coming out of the last 5-10 years, I think we are getting more and more confused, but all these are there, and I think we should be closely looking at and trying to achieve what the surgeon's philosophy is and trying to get the alignment, what he wants. And I believe probably a tool like a robot or a navigation is the way to go if you are aiming for these kind of alignments which are available, and if you want to follow them. We know Bellamant study which says that if you are attaining for a neutral alignment in a varus knee, you might end up doing a little bit additional release than what is really needed. So with that as background, and one of the recent classifications which has come out published in the Bone and Joint Journal, the coronal plane alignment of the knee CPAC classification, which is showing us in each varus, neutral or valgus knees, you can again, depending upon the joint line obliquity, classify them, and in total they have put it into 9 categories. These 3 X-rays are my patients who landed up last week in my OPD with knee pain, and I just took a long leg X-ray and started drawing these lines, and you can see the joint line obliquity is different from in each one of them. So these are the classifications, and this is how the information has to be taken by the surgeons and trying to achieve what philosophy they follow. So one of the cases which I'd like to show is a regular left knee medial compartmental. It's almost like a 67-year-old female with a tricompartmental OA who wanted a total knee replacement. You go ahead, take a long leg view and draw the angles, the hip knee angle of about 8 degrees, the proximal tibial medial angle of about 3 degrees, and the distal femoral lateral angle of about 3 degrees. And then how we go about planning these in robotic surgery is, I'll just put in a small video here. So we have the macro product specialist who come in and take the CT scan and feed it into the computer, and they segment the whole bone, and then they make a 3D reconstruction. And once it is available to us, you can look at the anatomy of the patient and choose an appropriate size implant, whatever size you want, whether your implant is going to be oversized or undersized. You can look at how the trochlea matches onto the femoral implant and what amount of rotations would be ideal for that particular patient. You can look at the posterior condylar offset and see whether the particular size of the implant matches to the natural anatomy of that particular bone. And I don't think in a normal jig-based surgery, we ever do this kind of critically looking at each patient's anatomy. You can see all these plannings are done even before we scrub in. You're sitting with your product specialist and then trying to see how that anatomy of that particular patient can be matched onto that implant. So here you can see how much you can rotate the whole bone with the 3D scan, see how the posterior osteophytes are, what's the posterior slope. One of the advantages of this particular system is that you can fix, there is something known as the anchor system, where you can fix onto the center of the implant or to the edge and then slowly rotate and adjust the gap space and the position of the implant in 0.5 degrees or 0.5 millimeters, which is extremely small and accurate. So in that way, you can adjust and fine tune your whole positioning of the implant, and also the gap balancing, whether either inflection or extension. You can again rotate the femoral component in either keeping the anchor in the middle or by the side, and then rotate the implant so as to adjust the flexion gap, or fix the anchor on the lateral or on the central part of the femoral component, and tilt and get a varus or a valgus position of the implant in, again, 0.5 to 1 degrees, which is extremely precise. And in the same way, the slope, which is again a big opinion among the surgeons, is going to be so much different. If you ask each surgeon how much slope they're going to put, it depends on the implant, the native slope, and the surgeon's philosophy. So whatever the surgeon has in mind, you can do that with this particular robot to be very precise. In the same way, if a particular instrumentation needs you to put the femoral component in flexion of 1, 2, or 3 degrees, that also can be done. So all these planning are done pre-operatively even before you scrub in. So much of planning you naturally do when you have this kind of robot. But I think in manual, we just look at the X-ray and then go ahead and do our surgery. That's how we've been doing all these years. So once you get your position, implant size, position, and the accuracy and the gaps in what you want it to be, then you open the knee joint, and intraoperatively you can start by doing your ligament balancing. You can put in stresses and see how much the joint is opening out on the medial lateral side. And depending upon your releases, you can get your extension gap, what you want, equal, or if you want to give a couple of millimeters laxity on the lateral side, that also can be done. And here you can see the flexion gap is a bit tight on the medial side. So all you have to do is that you can just intraoperatively rotate the femoral component externally, whatever you want to match the gaps, both the flexion and extension, and then go ahead with your cuts. So this is finally, you can put your trial implants and see how things are going. And what has been quite surprising to us in our institute was what you have planned is what you get in the post-op X-ray. Once you draw, what we have planned was for a mechanical alignment with almost 90 degrees of the femur and tibia to the mechanical axis. So we could publish this, both the accuracy of the implant positioning in the total knee replacement and also in the unicondyle knee replacement. The accuracy was quite surprising, and the first 50 cases, we were always surprised to see that the implant size and the implantation, the precision was quite good with this robot. And another case where most of the Indian cases with some laxity on the lateral side in varus knees, again, you take a long leg view and draw these angles, and then you go ahead and plan the gaps or the positioning of the implants according to what your philosophy is, whether it is mechanical alignment or kinematic alignment. These are the kind of knees which come to us very frequently, where the lateral side opens up quite a bit and the medial side is quite tight. So once you go intraoperative, you try to balance these figures and get the balance right. Here we were planning for about 2 degrees of varus for the tibial implant. And once you make your cuts and put your implants, and then once you finish your surgery, your post-op X-ray shows that what you're aimed for is what you are getting. Your total HKA angle is 2 degrees, and the tibial angle is about 2 degrees, with the distal femoral was almost 0 to 1 degrees. So I think for the lack of time, I'll go ahead with the questions. I think I'll try to go what we are thinking here. So one of the perceived advantages was the macro-robotic haptics, which prevent to a large extent the soft tissue damages. And what we mean by haptics is that there is a boundary around the bone where the saw blade is prevented to go outside this boundary and cause damage. So that's quite useful to us. And there are a couple of papers, especially from the Haddad group from London, where they looked at, they gave a classification known as the Musty classification, where they looked at the damage caused to the surrounding soft tissue with the saw blade, especially when institutes like where there are a lot of trainees, fellows, and they found that probably robotic based, if you have a tool like a robot, the soft tissue damage is much less, and the systemic inflammatory response following a totally replacement is much less following a robotic surgery compared to a jig based surgery. And one of these classification, the CPAC classification, which is throwing in a lot of information to us regarding the alignment, the joint line obliquity. And if as a surgeon, your philosophy, you want to follow the different alignment patterns, the kinematic alignment or the restricted kinematic alignment, and if you want to achieve something close to that, I think this is the technology which might be useful to you and useful to you. And in the same way, the anchor tool is so precise and gives to you the precision of 0.5 degrees to 0.5 mm. So that also to helps us to a large extent to keep the implants in the position what the surgeon wants. And 3D CT scans, of course, it helps. And also, these are some of the other examples of the cases. And of course, when you have a lot of implants around, either navigation or robotic is the way to go. And in summary, I would like to say that from our usual flow pattern of manual surgeries of cut, assess, and balance, in robotic, we kind of do a planning, assess, balance before even starting the surgery, and then go ahead with the cuts and then do the fine tuning. And we know that the 3D CT scans we take do give us high accuracy for matching that implant to that particular anatomy of the patient. And also the anchor tools, which helps to open the gaps, either the medial or the lateral side, and to balance the gap. This is an excellent tool. And whichever alignment philosophy you follow, I think this, and if you want to reduce the soft tissue release, probably this tool will help you to a large extent. And of course, the haptics prevents some soft tissue damage to a large extent, and the bony preparation is very precise. And if you have gross deformities, you can again start your cuts and then there is the ability to recut and also to do less cuts and progressively improves your cuts to balance the ligaments with this system. And to my colleagues, I would certainly like to say, if you have this technology in your institute, certainly it will give you a very accurate and precise implant positioning and alignment. Thank you very much for your listening.
Very much, Jay. Fantastic talk. Unfortunately, not a lot of the faculty or the audience are pure robotic users. So any questions from the faculty for Jay before I look at the questions from the house?
Jay, I have a question. You saw the Pradeep's cases and Parag's cases, like with the stress fractures, with severe varus deformity, with segmental defects and all these things. I am not a robot user or neither a computer user. Just I wanted to know what is your take on that, handling those cases using your robot. Severe varus deformities where there are segmental defects, almost more than 50% or more than 50% segmental defects. How do you handle those cases using your robot, or it is difficult to handle?
I don't use robot when those kind of gross deformities or huge bone losses are there, where you have to use a stem and you might have to use a wedge. In those things, I would stick with my standard jig-based surgery, and you go with a mechanical alignment. I think the robot is important if you are looking into those, standard cases where we know that 20% of our whole totally replacement patients are unhappy even with beautiful looking x-rays. So if you want to fine tune your implant positioning and accuracy, and if you believe a little bit on those kinematic alignment or restricted kinematic alignment, and if you are aiming in those ways, I think this is an excellent tool to have, but not for gross deformities or revision scenarios. I don't think we have reached that stage. Probably in very expert hands, probably it can be utilized, but it is just a tool to assist the surgeon. It is the surgeon's philosophy, what he has to do, and he can get it out of this machine. That's as simple as that.
Mohanty, can I make a comment, Mohanty?
Yeah, sure.
Yeah, Pradeep, followed by Professor Karim. Yeah, Pradeep.
Yeah, I think for most of these kind of defects where you're going to be using a stem, finally your cuts are going to be based on the angle of which your stem is going to be making with your implant. So it's going to be an intramedullary cut, and so your robotics really don't play that much of a role. The issue that I sometimes have is when I'm using stems with a femoral bowing. And then especially when you have a varus with a femoral bowing and you need a stem, that's when I have problems. Does anybody have any experience? And because I've had failures because of that.
Okay. So I'll tell you what I learned from Kelly Wins, though it's not possible to practice here because we don't have those. So what Kelly Wins would do is that he would put in a trial stem with a trial femoral component where the femoral component practically rocks onto the stem. and he would actually adjust the angle between the shaft. So the stem goes into the shaft, and he would adjust the femoral component till that time it's perpendicular, and then he would lock it in that position, and he would lock a short stem in that at that angle to the real femoral component and put it in. So that way, the stem which you originally decided the alignment went way up into the canal, but then the real stem is short, but it makes sure that your femoral component remains perpendicular to the mechanical axis. But otherwise, like you said, unless you are using navigation, that is one way for you to sort of reach that, get your femoral components position right and use a short stem. Definitely you can use only a short stem with that. So navigation would be the other way. I don't know about, Jay can tell about the use of robot in that.
Okay. No, I think, I think the stems designed are basically all the implants are for mechanical alignment. So if you want to change the position of the implants a little bit, I think the option is to use cemented stems and then manipulate the implants in the position you want. Robotic, I don't think robot has much of a role as of now to do these kind of difficult cases, gross deformities or gross bone loss or severe bony deformities. It is a bit tricky. Probably we might reach that stage, but as of now, we are just finding how useful it is in our regular cases and then proceed from there.
Yeah, Professor Karim, you're,
yeah, actually, it was just a question. Thank you very much for this interesting talk. And I want to ask you to elaborate more on the cost issues and whether it's justifiable in some places like the developing countries, like, for example, whenever, especially in the economic burden worldwide. How would you elaborate on that, please?
I don't think India is in the developing country category as of now. The situation in my hospital is that the hospital got this implant. It is a costly implant. I don't think many hospitals can afford it. But if the management can afford it, luckily for me, whether I use it for a regular jig-based surgery or a robotic surgery, the cost to the patient is the same. So that's a fantastic scenario for me. It is just a tool which I can use in an indicated patient. So I have the freedom to choose when to use robot, when not to use. And cost-wise, I am sure the private hospitals or the management is not going to recover that cost by the current pricing, what's happening throughout the world. But it is a tool, I think, which we can utilize. I think in the future, the price might come down and probably many more hospitals can use it. And hopefully, I think it's an excellent tool. I think it's going to be the future.
And Andrew, you wanted to
Can I request Andrew for his comments on robotic TK and what is their practice and their philosophy on how the robot is?
Yeah, so at the moment, we don't routinely use robots. And so, so we manage other ways. And I think we're trying to get closer to the truth by individually assessing and planning the alignment for each patient, rather than trying to just do a slightly more accurate cut with a robot. Because my only issue with the robot is you can get very, very accurate, but unless you think about the other planning issues, you don't know what target you're actually aiming for, but you can very accurately get that target. So I think we need the robots to be used for research to tell us what the target is, and then we need to find a simple way of getting there that's cheap.
Okay.
I truly agree with Andrew, because basically we don't know what is good for that patient. We can achieve the numbers through the robot, but we really don't know what is ideal scenario. Mechanical alignment, we know, but if you are going for the rest of the kinematic or restricted kinematic alignment or whatever it is it really good for the patient? If you put in a tibia in 5-6 degrees, those long-term data we just don't have. So you have the tool, but we just don't know what is exactly the ideal position for each of our patients. So that's what I think the research need to be in future.
Dr. Parag, just one quick comment from Dr. Parag, because he's heading an institute, and how far, and he is managing cases right from the downtrodden poor people till high class patients, affording patients. What is your take on robots? Suppose you as a hospital administrator.
No, I have done a lot of research myself.
How cost effective and how it should be utilized.
Yeah. So, first let me give you my comments about the robot. I think in India, Pune has the maximum number of robots, and yet my hospital doesn't have a robo. The simple reason is I am still not convinced about the robo as of today. Tomorrow is a different day. I don't know. I might change and we may get a robo. And believe me, it's not about the cost. There are 3 companies waiting to park the robo in the hospital without a charge. They say use it for 15 cases and then you decide. So it's not a cost issue. For me, it's still, the utility. And as Jay was saying, you can get it into 3 or 4, and what Rajesh was saying, 3 degrees or more. So the robo will help you get it. But what is the right alignment? The robots will tell you that. It'll give you what you put it in. So I think the time for me is not come yet to use a robo, but tomorrow is another day. To answer your question regarding the costs are going to come down, and in another 6 months to 1 year, you can hire a robo and keep it, case-based. The inventory is getting smaller, the sizes are getting smaller, is more user-friendly, time is less. So probably the cost won't be much of an issue. And from what I'm hearing and from what I'm gathering, I was completely against robos a year ago, but today I think, after hearing the talk from Jay, and also at the APAS, there were some robotic surgeries done in the last held. So I think robo might be a good idea, because if Rajesh is saying that you don't want to put the tibia more than 6, and how do you know that it's more than 6 degree varus? So I think a robo or navigation can help, because those things are for sure. So if there's something, a tool to tell you that, then you should have it. So these are my comments, Mohanty.
Thank you.
Basically, a calculated error that you want to make, which is helped by the optics of either navigation or by robotics. That will help you to get you to this 2 or 3 degree of planned alignment, which may be in normal this thing a malalignment, but that may be the ideal constitutional alignment for that patient.
Okay.
Yeah.
So we've gone through a lovely session, lots of questions. Yeah. I can't see any major questions on the chat. So while people express their doubts on the chat box, may I request Andrew to start with the summary of the entire program with the do's and don'ts. And the faculty can chip in with their add-ons to the take-home points for all of us.
Right. So what I've been asked to do is just put together a couple of cases, a couple of tips, a couple of practical things to try and bring together some of the learning points from this Varus knee summary and session. So if we look at this first case, patient with a complex open fracture many years ago, very stiff knee, but now painful and arthritic. And so obviously there is a varus malunion of the distal femur. I think probably the most important thing with this case as a sort of learning point from this session is if you're going to start talking about alignment, you have to get long leg films. You have to know all the information to know what you're dealing with, because what seemed like a distal femoral varus is now a multi-level malalignment issue. And so with this particular case, we went and took biopsies because of the old infection. We freed up to see what movement we had and what the bone was like. And the distal femur was completely destroyed and offset, so you couldn't seat an implant on it. But we've then had to treat this with a 2-level osteotomy of the tibia and distal femoral replacement to deal with the femur that was in a number of pieces. But overall, you can then get your goals of a stable joint that's well aligned. And there's always some concern about getting the multiple level ones to heal, hence the offloading plate. But over a 2-year period, it's integrated, it's fixed, the osteotomies have healed, and the patient is pain-free and has the best movement they've had for years. So I think mainly with this one, the issue is assess the alignment, get the long leg films, and then you just need to make a plan that's going to correct the things that are wrong with that knee. We look at this case, for example, very young, so 41 when I first met him many years ago. And at that stage, he was essentially, he'd been told he needed a total knee on the right, and he was a bit varus and a bit worn on the left. And at that stage, I thought, well, I'll do the easy thing, which is the osteotomy on his left, because I thought he was too far gone for the osteotomy on the right. But he actually was delighted with the left side and wanted an osteotomy on the right as well. You can see it's quite a large correction. I think we opened it about 17, 18 mils. And I was a little bit skeptical that that would do a good job for him, but particularly with his lateral ligament issue as well, that actually bought him 11 years of good function, good pain relief. And eventually now into his 50s rather than in his early 40s, he's finally come to a point of arthroplasty. So I think some of the points from that one were just the power of alignment and the power of realignment with deformity, particularly in the younger patients. Probably don't overcorrect your osteotomy if you think you're going to be going back with an arthroplasty in the near future, but also then have a thought about the bone quality from where the previous surgery is. Well, in those who've had a lot of deformity, we haven't really touched on it today, but often with the severe varices, the lateral side of the knee can be quite osteoporotic. And if you then correct them too much over the other way, they sometimes subside or sink into their osteoporotic area. So here the stem on the femoral side was just to do with osteoporosis, whereas the stem on the tibial side was to bypass the area where his bone quality on CT scan was not good in the area of the old osteotomy. So consider realignments, particularly in the young. This is now, sorry?
You were muted actually.
Oh, sorry. Which bits did you miss? Was that muted from the start?
Just a couple of words from the last slide.
Oh, sorry. Okay. So with that last one, the cemented stem was because of osteoporosis on the lateral side because of his long-standing varus, and the stem was bypassing an area of poor bone quality where the old osteotomy had been on his tibia. This pretty much an easy varus knee, just a bit too far gone for a uni for me. So our standard technique would be to measure their angle on the femur, decide if we're using that or maybe 1 degree less to give them that 1 degree of varus sort of sympathy, if you like, on the femur, but still with the majority of these just aiming for a mechanically aligned tibia rather than risking more varus. One of the interesting bits about bone cuts is if you look at planning for the individual and then doing an accurate bone cut, Katani suggested that once you get the bone cuts right, and this was with a 90-degree tibia and a little bit of flexibility on the femur, you almost never need to do any releases on your varus knee. So a lot of it about the power of where you put your bone cuts. In this case here, a little bit more severe, and once you start getting past about 15 degrees, you get more osteophyte, you start getting the tibial plateau expanding. And that's where certainly the main learning point would be that you must remove all your osteophytes and probably reduce that expansion of the tibia before you start playing with any ligaments or balancing of soft tissues. Lateral laxity, so here, for example, it looks a little bit like the lateral side is opened. Sometimes that's just a rotational impression from the x-ray, and when you get in there, it's quite unusual to have to do a lot to that lateral side. But if so, your options are to increase your constraint or consider the sort of epicondylar sliding osteotomy on the lateral side to tighten up if you don't want to use the constraint in the implant. So in this sort of case, a big effect on any release or balance just by removing the osteophytes. And so you can, with standard sort of PS constraint here, and just removing that, get nice mechanically aligned knee and no releases at all. The more severe knee that we saw some pictures of earlier, and certainly some great examples in this session, I think one of the things we picked up from this session, once you start getting to the more severe ones, you have to be concerned about their obesity, their osteoporosis, the bone quality, and the bone loss. So the more severe the deformity, the more you have to plan. What I would suggest with these ones, draw in your alignment, draw in where your standard resection will get to, and then you will know if you can maybe just go to a 10 or 11 poly, which you'd probably just go for a flat cut. Or once you draw on the base of your defect, you know that you're then going to have to make a plan on that medial side, either with bone graft and bypassing with a stem, or possibly revision implants with an augment. One of my issues with kinematic is that obviously in this group of arthroplasty surgeons, there are a lot of experienced guys on the call and women, but this is an attempt by a surgeon to do mechanical alignment. So there are a lot of surgeons out there not doing big volumes who really even struggle to get implants aligned when they're aiming for mechanical. And here, not just the obliquity, which subsequently did lead to early failure of the base plate, but also the fact that that has an influence on your medial balance. And you can see the gapping even on the early post-operative film. So in terms of some practical tips, all our joint replacements, we get long leg alignment films. It was initially a bit of a fight with the radiologist, but we won that fight about 15 years ago and we haven't regretted it. I will always measure the angle between the mechanical and anatomical alignment, and that'll be my starting point for my valgus alignment cut on the distal femur, but also have a look at where that entry point enters the knee, because you can introduce 3-4 degrees of variable alignment just by choosing a slightly different entry point for your rod, even if you've nicely calculated what that angle should be. Overall, just make sure you're making the right cut, so measure it first, twice, and then try and cut it properly once. One of the most important failure mechanisms or errors I see with varus knees is where they are overcorrected into bad valgus, and that's normally done with femoral valgus, where even though you've measured the angle you want, the surgeon then implants the jig, they hit it down on the lateral side, and so instead of seeing this gap that you should see on that lateral side, they hammer it down so it sits on the bone, and immediately they introduce an extra 3-4 degrees of valgus deformity onto the distal femur. On the tibial side, I always use a pinned rod at the top, so I know I'm in the ACL footprint, and then I can adjust distal alignment. But also simple things like put your central pins in first, don't use the peripheral pins. That medial pin always hits the curve of the tibia and drags your block into varus. So put a third pin in for additional stability, and then I always start the cut with the jig still on, and then remove the jig to complete the cut. So I've got an additional measure of security to try and achieve what I was aiming. And this is what I think with our trainees, we've got to try and get them to be able to do a perfect 90-degree tibial cut routinely and consistently before they start trying to think about playing with any other variation of that cut. And one of the things that I think is really useful, particularly as you start trying to think about this issue of alignment and balance, is once you've done your bony cuts, put those two cut bone ends together, go to the end of the table and have a look what alignment you've got. Because actually a trained orthopod who's thinking and taking the time can pick up a difference of a degree or two in alignment. You can see that change. So put the cut bone ends together. That tells you what you have cut for. Then if you check your balance and you find that you're a fraction tight medially, you can then choose whether you're going to add a mil extra cut to the medial plateau or whether you're going to do any additional releases. But you at least know that you're starting from a position where that leg was straight. So in terms of take-home tips, I think the key bit for me is assessing the alignment and appreciating the deformity and correctability of that. I tend to plan for mechanical, particularly I suggest when people are starting their careers, or if they don't do many, it is the safe option. And you're going to aim, particularly the more severe it gets, you're going to aim more for neutral. But in those, shall we call them American knees with the very mild disease and so on, some of those, if you want to start playing, slight undercorrection is probably not a bad thing on the femur. Sorry, on the overall knee, but you don't want much varus on the tibia, certainly not more than 5 degrees, even with the mechanical or kinematic versions. I think the kinematic is for the enthusiast. You really must be experienced. You must thoroughly understand what it is you're trying to achieve. Probably with the restricted KAs, you're safest at the moment to avoid the bad outliers and wear issues. And that probably means additional technology to enable you to do that. For a bone loss point of view, plan it carefully beforehand. Don't be surprised in theatre. It's usually on the tibia, and we've had a great talk on how to address that. Always remove your osteophytes and reduce that tibia before going to release your ligaments. And if you do the right bone cuts, you should very seldom need to do much in the way of ligament releasing with a varus knee. If you are tight laterally on a varus knee, you've probably got your bone cuts wrong. Go back and have another think and assessment of your bone cuts. If you're releasing on a standard varus knee, it's probably because you're correcting an extra articular deformity, or because you are substantially changing their alignment from what their own natural alignment is. And probably a final take-home thing, if you're going to be a knee arthroplasty surgeon, varus knees are your bread and butter, you're going to do it every day of your life for a long career, make sure you enjoy it, you try and understand it, and enjoy the process of thinking about it and doing it. Otherwise, it's a very long career doing something if you don't enjoy it. Thank you. And any comments from the rest of the faculty to sum up the session?
Thank you. Thank you, Andrew. Those are great points. Abhay, anything to add?
I think I can't see any questions in the chat box, sir. So I'll just invite our faculty for any outstanding take-home messages if they have, or else we can invite Corona Remedies to just show their slides before we wind up.
I just have one question for Rajesh.
Yeah.
So, and Rajesh does treat a lot of the stress fractures. So what is your regime post-operatively if you've proven the case to be an osteoporosis? What do you use in the post-operative period? Because it's so confusing. I was trying to read up some literature and there's no consensus on what to use.
Yeah. So I'll tell you what my understanding is. One thing is that all patients have to have calcium, phosphate, alkaline phosphatase, vitamin 25 or vitamin D and PTH assessment. So that needs to be corrected. Now, the general principle is that if you are using a cementless implant, then something like teriparatide works very well. There are a lot of studies which show that the screw pull-out strength from the osteoporotic bone or the bone formation around the implant is much better with teriparatide. So if a patient anyway is also osteoporotic systemically, I would give the teriparatide. However, we know that in a cemented implant, particularly in the cancellous bone, like knee replacement, the osteocytes are actually recruited. So osteoclasts are actually recruited. So for those cases, actually some kind of, the anti-osteoclastic factor treatment is useful, whether you want to use bisphosphonate of any kind, oral, parenteral, or you use denosumab. So that's what I would use, in a patient like that. But if it is a patient with, say, non-union of proximal tibia, where union has been a problem. See, one thing is to come with a stress fracture, incomplete fracture, or complete fracture. One is a long-standing fracture with pseudarthrosis kind of thing with the hypertrophic non-union and this thing. Those are the cases where I would be tempted to use the teriparatide in the interest of union. But otherwise, by and large, in these cases, I would use some form of anti-osteoclastic treatment, either denosumab or the zoledronic acid or bisphosphonate. Oral bisphosphonate.
Okay, thanks, Rajesh. There has to be some rationale. The problem with bisphosphonates, what I've seen is that sometimes, we talk on the femur, we see the insufficiency fractures. So I've moved away from bisphosphonates. I either use, now what you said, teriparatide, I like it. The only problem with that is the compliance,
Yeah.
Patients just in 3 months or 6 months, the fracture is united and they don't want to use it for 1 year. So that's a problem. But I think denosumab seems to be quite promising.
Yeah, you're right. Just a quick comment. If you have a lot of osteolysis when you are revising, they are all mediated by osteoclast. So you can't avoid bisphosphonate there. Of course, the stress fractures are a problem. But what we do is anytime we are giving annual bisphosphonates after first 2 injections, we take X-rays of the proximal femur of the patient to see that they are not developing anything. And usually, if there is any suspicion, anything, we would just stop it and shift on to teriparatide or stop it. Just one comment to Andrew, it was said that, the extensive releases should not be done. And I agree with that. Hardly ever I have done the superficial medial collateral release. And there was a very old study quoted by Dr. Abdel where he said that the non-union rate of the medial epicondylar osteotomy is very high. What my problem is, some of the seemingly mild virus, the kind which you showed, have a severe tibial bowing in Articular. So it looks very nice if you take an X-ray of the knee and it shows you mild varus. And when you make a cut perpendicular to the anatomical axis, you have a tibial cut which is way valgus. And then you don't know how to reduce that. So what we have started doing is to leave them in some amount of varus, add a stem. I do normally a CR surgeon, so I'll relieve the PCL completely and put a stabilized insert. But what I'm saying is, I know the releases are also determined by the bowing of the tibia, which is a kind of extra-articular deformity. And sometimes you can't help. You're going for mechanical alignment, you end up making a valgus cut to get your rod where you want it to fall. And then you realize that, you've got a real trapezoidal space with tight medial side. So two things on your comments, one about this and the other one is your experience with the medial epicondylar osteotomy.
So you're absolutely right. Unless you get those long films, you will often miss a tibial bow, which is your extra-articular deformity. And there are even subtle medial arthritic patients that have valgus bows of their tibia as well as varus bows. So I think as soon as you start looking at those extra-articular deformities, then you start getting into the realm of having to go back to, if you like, old-fashioned releases, because you're correcting an extra-articular problem intra-articularly. In those ones, I will usually be doing extra-articular, extramedullary alignment on the tibia, and I will have a look from my planning as to whether that gives me a crazy cut, in which case I might choose to partially correct that. But if it's a subtle bow, I will choose to probably fully correct that. So I'll do my extramedullary properly aligned, so it's 90 to the mechanical axis, but accept that that will mean I'll need a bit of releasing. In terms of the medial epicondylar sliding osteotomy, it's something that I almost never do. I've occasionally done it in a young patient with a severe varus on the lateral side to tighten up a lateral side where I didn't want to put a hinge in a young patient.
Thanks.
Thank you. Thank you, Andrew. Before we close the session, I have a couple of announcements to make. Now, it gives me great pleasure to announce that we are going to hold a physical conference, that is a Silver Jubilee of Indian Arthroplasty Association conference. Actually, we completed 25 years. In 2020, the conference was supposed to be held in Coimbatore last year, but unfortunately, due to pandemic, we had to postpone it, and now we are holding it in Mumbai this year. So we have named it as IACon 2021, like that. So it was supposed to be in 20, but right now it is 21. So it's on 22nd to 24th of October, and it will be a physical conference following all the government regulations. There will be, we are planning 3 or 4 live surgeries based on uncemented knee. There may be, patellofemoral arthroplasty. There will be robot-assisted total hip replacement, and blah, blah. So we are planning a couple of, surgeries from outside the country. And plus we'll have a beautiful sessions and debates and didactic lectures, pre-paper sessions, technique-based videos, all these things. So please reserve your date and block your dates, and please attend physically in Mumbai. And the second important announcement that we are taking out a special issue on arthroplasty. We have finalized the articles, and actually all these articles which have been gone through the peer reviewing process and been selected will be published in this special issue. There are almost more than 30 articles, so it will be a really thick volume of Indian Journal of Orthopedic Specialist on arthroplasty. And we are planning to give a hard copy during the conference itself to all the attending delegates. However, you will receive a soft copy as well, but we'll be giving during the conference. Moreover, all our 20 webinars will be, the recording of all the 20 webinars held during the last year. We'll be giving a pen drive with all the recorded 20 webinars. So it will be ready-made, reference in your hand for all the difficult and primary difficult situations. And there are many other things in the pipeline, like we may have our IAA neckties, what is scrub dresses, etc. So as you open up, I will tell you in detail. Our next webinar will be IAA webinar interactive series number 20, which will be focused on approaches in total knee arthroplasty. It will be the third Saturday of next month, that is 18th September 2021 on Saturday evening. And the convener will be Dr. Vikas Kapoor, who is a joint replacement arthroscopic surgeon, and he is at present the vice chairman of group director of Medical Institute of Orthopedic Sciences, based in Kolkata. So all of you are requested, please attend this webinar next month. Now I hand over to our friend partners, industry partners, Mr. Siris from Corona Remedies, and I will stop sharing the screen. Siris, we thank you very much, for providing academic support for this event. Over to you.
It's a pleasure, sir. I'll not take much of the time. It's already late, but it would not like to miss out on thanking you, Dr. Mohanty, and all the dignitaries. Now, it's absolutely pleasure for a young company like us, just about 14 or 15 years old, rather 14 or 15 years young, I must say, to have this opportunity to get associated with all these dignitaries. It's a pleasure. Not much, just a couple of slides to share about who we are and where we have reached. So I would just seek your permission to share this slide, sir.
Yes, please.
Yeah, I'm sure it's visible, right? So yeah. So basically, as a company, as I mentioned, we just got incepted in 2004. So just about completed. We currently operate with 6 marketing divisions, catering to various specialties. We have our footholds in about 12 countries now, currently present into Africa, Asia, and CIS countries. This is where our international business is present. We have in place our recently, operative PICS approved manufacturing unit, which should give us an entry into now more than 56 countries worldwide. So, and happy to share with you that recently, just a year back, we have got our approval from the Department of Scientific and Industrial Research for our in-house research and development center also. So today, as my name is Shirish Randive. I represent the Pioneer team. I work as the Associate Vice President Marketing over here. And this is a division which caters to primarily, into the therapies of anti-osteoporosis, bone health, and pain management. And, our flagship brand obviously remains the teriparatide range, where do we have all the 3 options, as you know, sir. So not much on the product front on this forum, but yes, we do have this thing. And the only salient feature what we talk about is we are the largest company in terms of the reach. We have our affordability being the at the forefront of this therapy. We are the most affordable teriparatide today available in the country, and we are available at more than 550 with medical reps. So that ensures your patient do not suffer as far as the availability factor is concerned. Thank you so much. And once again, it's a great pleasure for us to have been associated with this prestigious forum, sir. Thank you so much. Thanks a lot.
Thank you, Siris, your academic support for this webinar. Could you stop sharing your
yeah, sure.
screen,
I'll do
please?
that. Yeah, yeah, yeah.
Before ending this webinar, I must extend my heartfelt gratitude to Andrew Proteus and Mohammad Abdul Karim for joining us today and staying entirely from the beginning till end and providing, sharing their inputs for the management of TKR in Varus knee, which is so common, yet, we don't know so many things also about it. Thank you very much for joining and your time. In addition to that, we also thank our faculty, Professor Rajesh Malhotra, Professor Parag Sancheti, Professor Pradeep Unuj, and Professor Jai Tilak for contributing their part and for showing so much of difficult cases and how to handle a Varus knee typically in our Indian situation. And I must thank Ave, for the last couple of months, he has been putting so much of efforts, inviting people, joining the things together on behalf of Indian Arthroplasty Association. I thank you for being the convener. And on the background, Dr. Swapnil Kenny, the assistant professor in King Edward Memorial Hospital, Mumbai, and Dr. Ronak Kothari, my registrar. They are working in the background for the YouTube, for the Facebook, etc. We thank them. Have a wonderful evening and thank you. See you soon face to face.
Bye.
It's been
Good night.
Bye.
Good night.
Bye. Good night.
Good night.
Bye-bye.
You can stop the live streaming.